Hi, everyone. We're going to get started. Everybody could take their seat. We have two absentee people at the moment. Dr. Lieberman is going to be a little bit late, so I'm going to do some of the introductions in his behalf. And Eric Hadar is also stuck in traffic, unfortunately, but he is on his way, but I'm still going to sing his praises without him being here, and I'll introduce him when he does arrive. But we're really absolutely delighted to have Kathleen Carroll. She's really been someone who is truly iconic in the field, and when I describe her in a little bit, you'll all understand why. I'm going to try to keep my comments brief today, but I do feel I have to bring up a few issues. One is that I think most people in the department are aware that Herb Kleber died last month, and the sadness and shock is still with many of us today. And as stated, we put the memoriam that was in the New York Times in the back of the program. Herb started and really led the addiction field and was an advocate in providing respectful and evidence-based care from those suffering from addictive illnesses. Kathleen Carroll and I last night we were at dinner, and we were talking about the immeasurable impact that Herb has had on the field, and not just because of the impact on science, because of his exceptional and extraordinary ability to nurture and promote young investigators, as well as providing compassionate care to patients. Kathleen Carroll, like I, was one of the many clinical investigators that he gave guidance to and encouragement, and he really leaves an unparalleled legacy. And one part of this legacy is the establishment of the Eric D. Hadar Lecture Series and the Eric D. Hadar Research Fund. I want to state up front how grateful we are as a division and a department to Eric Hadar for making this event possible. In the fall of 2016, Eric D. Hadar made a generous gift from the Eric D. Hadar Family Foundation for $2 million for supporting substance use disorders. The gift established an endowment fund for a lecture, which is what we're involved in today. It's an annual lecture series, as well as a research fund, which advances research by providing resources for the fellowship and faculty support, as well as research projects and laboratory infrastructure, and including the Hadar Fellows. I want to take just a minute, because there's no other opportunity elsewhere to do so, is to introduce the two Hadar Fellows who benefit from Mr. Hadar's support. One is Carolyn Araud and Christina Breezing. Do you just want to get up and say hello? Okay. Hi. Carolyn Araud, Research Interest Center around the one in the black sweater. Intersection of substance use and pain. She's currently working with Dr. Meg Haney, utilizing human laboratory models of cannabinoid administration to study medication effects on the outcomes related to cannabis use disorders. She just recently got a multiple R21 with Dr. Ziva Cooper, analyzing the effects of various ratios of THC and cannabidiol on experimental pain and abuse-related outcomes. Her long-term goals is to identify safer, more efficacious treatments for pain in the context of substance use disorders. So we're very excited, and Carolyn just is putting in a K award, so we're hoping that will go through. Dr. Christine Breezing was in our fellowship. She just recently obtained a NIDA K23, identifying novel medications for the treatment of cannabis use disorders, its role in impulsivity, and implementation of ecological monetary assessments to better facilitate data collection during a clinical trial. Her research interests include medications development for the treatment of substance use disorders, and specifically cannabis use disorders. She's particularly interested in the utilization of mobile health technology to better assess and ultimately aid in the treatment of substance use disorders, in addition to the roles of impulsivity, quality of life, and stress. So we're very excited that both of them are our Hadar Fellows for this year, and we're pleased that Eric was able to support that. Although we have numerous established researchers in our division, without the generous donors such as Mr. Hadar, our young investigators would have a difficult time conducting and continuing to conduct their important lines of research. Clinical researchers are critical to development of breakthrough treatments, and I think they're sorely needed in the addiction field, particularly if it's going to expand and thrive. And when Mr. Hadar comes in, I'll make sure to, at the end of Kathleen's talk, thank him again, because it's really made a tremendous difference for our division. So let me now turn to introducing Kathleen, who's catching up with Ned in the front row here. Dr. Kathleen Carroll graduated summa cum laude from Duke University. She received her PhD in clinical psychology psychology in 1988 from the University of Minnesota and completed her pre-doctoral training at the Yale University of Medicine's Division on Substance Abuse, when she was promoted to professor in 2002. She's the principal investigator of a Center for Psychotherapy Development at Yale, NIDA's only center devoted to behavioral therapy research, and since 1999, she's been the principal investigator of the New England node of the National Institute of Drug Abuse's Clinical Trials Network, which then merged with Dr. Weiss's Northern New England mode in 2009. Dr. Carroll is the author of over 320 peer-reviewed publications, as well as numerous chapters and books. Her research has focused on the development and evaluation of effective combinations of behavioral therapies and pharmacotherapies, with an emphasis of improving the quality and rigor of clinical efficacy research in the addictions and quality of substance abuse treatment overall. Dr. Carroll has been a big promoter and an implementer of the stage model of behavioral therapies development, which is a useful framework conceptualizing how effective treatments can be developed, evaluated, and moved into the treatment system. Dr. Carroll is going to talk and describe her work over the last 35 years. I thought you were like 28, Kathleen. I don't know whether you got 35 years. This doesn't add up. On moving validated behavioral therapies from the research clinic to the real world via the stage model. Her work was originally and continues to be inspired by the late Herb Kleber, who devoted his life to improving treatment and outcomes for individuals with substance use disorders. As addiction researchers, we can honor Dr. Kleber's incredible legacy, focusing our work on making the treatment system more accessible, more equitable, and more effective. The title of Dr. Kathleen Carroll's talk is Adventures in the Dissemination of Evidence-Based Therapies, and I'm absolutely delighted to have you here, and I'm very honored to consider her both a colleague and friend. Kathleen.
Thank you. That was absolutely lovely. I'm so delighted to be here, and I want to go right there. First I want to talk about how absolutely honored and delighted I am to be here for the Hadar lecture, and to, when he gets here, thank him for the absolute vision and generosity of donating to substance use treatment and research. We just don't see that very much, and I suspect Herb had a lot to do with cajoling him there as well, but it's absolutely wonderful, and I had a great time talking to Christine and Crispy last night, Carolyn, and so thank you very, very much. I am going to talk about all the things I learned from Herb. This was going to be a top 10 from Herb, but I realized that he's in fact taught me everything that I know. But first, that's my email address if you have any questions. NIDA and NIAAA have been very, very, very good to me. And I'm a member in trust of cbtforcbt.com. And so I turned 60. I lost Herb. I lost my friend Nancy Petrie. I lost Bruce Rounsaville. And I've decided you only have that much time left. And so really, this is, coming to terms with what I want to do and how I want to make an impact on the field. And so cbtforcbt.com is about that. And it's not, I'm a member in trust, so I don't take any money. I won't take any profit. It's really just to make better versions of empirically based therapies and get them out there to the field. So I'll go through the stage model as a framework for treatment development through dissemination, using our work in CBT as an example. But throughout this, everything I owe to Herb Kleber. He, in fact, gave me the idea. I came to Yale as a pre-doctoral fellow. Didn't have any idea about dissertation. Didn't have any idea about clinical research. And as many people commented at Herb's lovely memorial, that Herb was absolutely extraordinary at looking you in the eye and sizing you up and figuring out what you were good at and then pushing you in that direction. And as Roger Meyer pointed out, he did that for hundreds of people. I'm sure the field wouldn't be what it was. He also taught us, I think, to have great respect and love the work and love working with people with substance use disorders. And the other thing that he taught, especially the Yale people, I think, was that there's no concept in psychiatry that you can't explain with a New Yorker cartoon. So this is for Herb. So this is the psychotherapy versus pharmacotherapy debate, good shrink, bad shrink, face your demons, take a pill. This is for Nancy. This is contingency management, so the little rat. Oh, not bad. The light comes on. I press the bar. They write me a check. How about you? And this is CBT. So let's just go in and see what happens outside of the pastry shop. So that's very important. So when I got to Yale and started doing clinical work, this is what empirically supported behavioral therapies looked like in the field. There were no manuals. There were very few systems. Yale was still sort of short-term psychodynamic. You sort of went behind the, you sort of went into the room, closed the door, listened a lot, and sent people to meetings. It really there wasn't much to go on. And, very proudly, we've come a long way in terms of new pharmacotherapies. But I think the progress that's been made in effective behavioral therapies is really rather extraordinary. In a relatively short period of time, we have motivational interviewing, contingency management. I highlighted cognitive behavioral therapy because that's what I'll be talking about. We manualized 12-step facilitation, and that works pretty well, and so forth. So we've really come a long way. And I think a lot of that progress was due to something that got codified as the stage model of psychotherapy development, as Dr. Levin just talked about. So we started it basically as a way to start building a field of behavioral therapies, because in order to get support in the 80s for any kind of research in behavioral therapies, you had to have certain things. The methodological bar was fairly high. You had to have manuals, you had to have ways of training therapists, you had to have some way of deciding if the therapy was being done appropriately or not. And so the problem there is that unless you had pilot data, or unless you were studying a therapy that was already fairly well established, it was really hard to get in there. So the stage model, which is sort of now in there in the R2133 system as well, where you can get pilot support for novel approaches. But we started with 3 stages. So stage 1 would be treatment development, manualization, and so forth. We would then go on to stage 2, which would be randomized trials, looking at mechanisms, mediators and moderators, and then finally move it out into the real world. You can hear me in the back? Okay, good. All right. And so we basically did a lot with providing a way for some novel approaches to really come into the field. So the stage model was a way for rapid and systematic dissemination, a development of promising treatments from just really good ideas to where they could be ready for dissemination. Welcome. And by supporting stage 1 research, the field was open to richer and a more diverse range of new behavioral approaches. And the thing about the stage model was not just new stuff coming in. It was staying with the therapy until it was developed and disseminated in the most effective and most potent means possible, which is much harder than it says. It's easy enough to come up with a manual and a trial or two. Getting it out to the field is extraordinarily difficult, as I'll show. But so this is the stage model actually has been now adopted throughout NIH, which is really rather remarkable. Like everything else, it got way too complicated along the line. But the notion here is that though there's more connection between stage 1 preliminary research and basic research, which is really nice and I think very, very exciting. Stage 2 is still doing stuff in the lab or the research setting, then moving into community clinics, and then finally to effectiveness studies. And this this is really the implementation cliff. This is where so many therapies just don't make it out into the real world for all kinds of reasons. But now I'll turn to what we've been doing with CBT. But one of the things that this is very Herb-like. We've had the Psychotherapy Development Center since 1994, and I think Bruce and I just learned to be very generous with people. Let them have good ideas, do stage 1 stuff, and let them rip. And so this is all that would fit on the slide. But we've basically started through the PDC over 15 separate independent satellite research programs at Yale, which are all going strong, all of which had their start in a pilot study or a small component study in the center. So, and the other thing is that the PDC has brought two treatments, CBT for CBT and Nancy Petrie's low-cost prize contingency management to widespread clinical use. That's pretty good for a center to get two treatments out there. But it's still fun, and we hope to get renewed again. We'll see. But now focusing on the work in CBT, we did probably 20, 25 years of work on cognitive behavioral therapy in combination with pharmacotherapy, contrasting with other kinds of work. Two things that we learned about it. One is that it's really, I'm going the wrong way now. All right. Okay, good. One is that compared to other therapies, it's fairly durable. It's a treatment that seeks to convey, instill, and help people practice cognitive and behavioral control strategies. And so since we're teaching something systematic, hopefully it sticks around with the people we work with, and it continues to exert effect even after people leave treatment. And this is from, I think, my very first study where CBT and just supportive clinical management sort of being nice was right here. And then clinical management did okay, but this was over a year of follow-up. People who were exposed to cognitive behavioral therapy continued to reduce their drug use even after they left treatment. And the other thing we found was that practice of skills was extraordinarily important too. So we just kept track of how many times people did homework, and this is follow-up data. And people who didn't practice didn't do terribly well during follow-up. Whether you did it consistently or you kind of did it in a kind of way, you did pretty well. So I think there's nothing magical about homework, but I think it is a predictor of whether the treatment's actually taking or not. So CBT lasts, and practice is a really, really big thing. But after those 20-odd years of work, we were nowhere in terms of getting it out into the field. There were manuals, there were videotapes, we did training studies, we did all kinds of things. A lot of programs and clinicians said they were doing CBT and other empirically validated therapies, but it didn't look like that to me, and we were able to get some data from a early clinical trials network study. This was a study in which we we're actually studying motivational enhancement therapy and MI, but what we did in the study was go to 11 or 12 good clinical programs throughout the country, get clinicians who would be willing to learn and get supervised in delivering motivational enhancement therapy, and the half that didn't get randomized to that would do whatever it was that they were normally doing. And these were all volunteers, and we asked them before they started, what kind of therapy do you usually do, and this is how much. So they did a lot of 12-step, and they said they did a lot of CBT, and they did reality therapy, whatever that is, motivational interviewing, psychodynamics. So they were doing a lot of stuff by their own report. And then we came up with one of my little Kathleen Carroll rating systems, which are cumbersome but reliable. And we listened to 379 tapes of treatment as usual, so what's really going on in clinical practice. These were early sessions, people knew they were being taped, so on and so forth. Did that flip? And this is sort of what was going on. So this is our adherence rating. So 1 means it didn't happen at all in a session, 2 means it happened once, 3 means it happened twice. And 4, 5, 6, to get ratings of 4, 5, 6, it's got to be there in some depth. The clinician really has to talk about it, make sure the patient understands it, and so forth. So of 379 tapes, what was going on a lot was some good stuff. So assessing substance use and assessing social functioning, a little program orientation. But these, out of 30 things we measured, most of what was going on was just undetectable. There was very little treatment planning. There was very little psychoeducation. There was very little talk about going to self-help groups and so forth. And so what was really, really shocking was what never happened. So this is flipping the scale a little bit, and this is these are interventions that occurred in less than 20% of all sessions. So out of 379 tapes, anything mentioning thoughts, cognition, paying attention to what you're thinking, anything like that happened 23 times. 23 times. Anything that remotely smelled of skills training was there, maybe 10 or 15 times of all those things. So for all kinds of reasons, clinical work is really hard. Clinicians have a lot to do. They're really pressured. Nobody really watches to make sure, and most out of educational teaching sessions to make sure they're doing what they're supposed to be doing. So it's been really hard to get CBT out there. This is famous, so I'll show this. When Steve Martino in our group was actually doing this as his postdoctoral work, and out of these 30 items that we had, they were just not getting rated. They weren't showing up with any frequency at all. And so we went to Steve and said, well, what's actually going on in these particular sessions? And he said, well, there's a lot of chat. And I was like, well, what is chat? And chat is, we defined it, and we can rate it reliably, and it's talking about the Yankees versus the Red Sox and the traffic and the weather, but it has to be initiated by the clinician, not the patient. So it's maybe, there's a fair amount of chatting that takes place to build an alliance, but we're talking about stuff that goes on for 20, 30 minutes in a session. And it has to be therapist initiated and not have anything to do with any problem the patient conceivably brought into treatment. So it's just filler, it's just stuff. And interestingly enough, when there were sessions with a lot of chat, the patients rated it as lower quality, not very motivating, and so forth. And so the last thing I'll say about this is now a comparison of the clinicians who were randomized, trained, and supervised in motivational enhancement therapy, and these were the treatment as usual therapists, and this is the level of chat. So by actually training clinicians in a manual guided approach, supervising them carefully, providing support for them doing a new therapy, we sort of got the level of chat down to nothing, and patients did moderately better. The other thing that we learned over the years about training is it takes a really, really long time to train clinicians to do CBT well. These are mostly master's level community-based folks, so they're not PhDs and MDs in a social work or a clinical psychology training program. But what we did here was randomize about 80 clinicians to 3 levels of ways of learning CBT. So they got manual only, which is sort of the de facto training method. Like, here's the manual, and maybe a one-day seminar. Good luck. Some people got our very, very early website, which I will admit to you was absolutely horrible, black and white, and not very good, but it did something. And then these people really got the Cadillac training approach. So they got a 3-day seminar, they got supervision, and they got feedback. And this is the level of competence that we would require in any of our, before we let a clinician in our clinical trials. So really the only type of training that got people to a reasonable level of competence was the full-scale method. And this is costing like $4,000 per clinician when you've got turnover like 50% in most community settings. It's just not going to work either. So we kind of had to go back to the drawing board. And being an astute clinician, I picked that up because when we were training clinicians, they always go like, well, how much does this cost? That's fine, Dr. Carroll, but we only do groups, and I can only do it in 5 minutes. So our carefully written, systematized therapies were just not getting out there. And so for CBT, up to about 15 years ago, I would say, we had very strong evidence, not that it was better than anything else, but it certainly was safe, broadly effective, had those nice durable sleeper effects, and we had done some training dissemination, but dissemination was really, really hard. Training takes a long time. It's a complex approach. Clinicians really don't have a lot of time in sessions to do it. Fidelity in the real world was pretty bad. There really isn't a lot of performance monitoring or supervision in clinical practice. And the thing that drives me nuts is that in the substance abuse field, we still have this persistence of, sort of non-specific group therapy. There's no evidence for non-specific group therapy, and that's all we do. And again, sort of getting to this stage in life, I'm not going to leave the field while it's still in this shape, so we're going to change that. So here, after all that work, we have our nice manualized therapy, delivered through a clinician, no matter what. Even in the best, well-controlled clinical trials, the dose of CBT is lower than you'd ever want it. At most, you're going to get 20 minutes in a session. And with patients with variable attention and trouble remembering, I'm not sure how much CBT they were getting at all. On the other hand, if you delivered it through a computer, one thing you have is a new way of disseminating it, standardizing it, and you have some interesting pathways for innovation as well, which we'll get to. So we developed, about 20 years ago, computer-based training for cognitive behavioral therapy for all kinds of reasons. One is just, as I've been saying, effective implementation of CBT is very rare. We all know only a fraction of people with substance use problems access treatment at all, maybe 10%, maybe 15%. Skill training with people with substance use disorders is really, really hard. And there was no way in, I think, most clinician-delivered forms of CBT we were actually getting people to learn those skills and make sure they could implement them. And again, this was never intended to replace clinicians. It's really a clinician extender. So the idea is that the clinician can meet with the person, assess their problems, provide support, build an alliance, do case management, provide medications as needed. And, you could sort of contract out the CBT because, that does get a little boring anyway. I'll admit that. And then there's some things that the computers can do very, very well. One of the things that it can do is provide examples of effective use of these coping skills. So we built CBT for CBT around these little movies where we have real-life actors from equity actors in realistic situations sort of act out very difficult situations where people are trying to resist drug or alcohol use. We then teach the skill using a whole lot of multimedia kinds of things. And then we run the movie again, this time showing the person using the skill under stress. So this is a very effective form of modeling, I think. You actually see someone using the skill, which I think is much more effective than a clinician ever just describing it. And the other nice things you can do for treatment research is, since you've got the treatment sort of split up into these modules I'll talk about, you can actually figure out, are there components of CBT that really carry the effectiveness? Are there some that are not doing anything at all? So it becomes a interesting way of making treatment more effective. And for once, we have standardized delivery, which I think is an interesting possibility. And so my collaborators, so Sam Ball and Steve Martino, Melissa Gordon, really thought about developing CBT for about 6 months before we did anything. One of the things that we knew we had to do was make it really engaging. I don't know if you've seen some of these training or CBT websites, but they're boring as all get out. I mean, somebody just took words and put them up on a page somewhere, and we knew your average person with cocaine use disorder or marijuana use disorder or alcohol use disorder is not going to sit there and read a manual. So we needed something that was really going to pull them in and get them to watch all of this and engage with the therapy and learn it. So that was job one. So it was convey skills and be entertaining. The other thing we wanted to do was really deliver a potent dose of evidence-based cognitive and behavioral strategies. So we wanted to make this a skill training machine. So our little computer program was not going to chat, and it was not going to be warm and fuzzy, and it wasn't going to provide support. All it could do was be a skill training machine. So we built it only to do that thing. We wanted to have the sleeper effect, so we really emphasized skill practices. So after the little movie takes place, the actors come back and they go through an example of how you would do the practice in real life. We walk the patients through it when they're doing it. We undercut resistance by having these testimonials of actors come back and talk about how wonderful it was to do homework, which actually people liked, so it's surprising. And again, I think the whole chunk of this is modeling, that you're actually able to see skills demonstrated in realistic situations under stress. And so just some more things. The other nice thing about it, we built it so no one can get hurt using it. So it collects no PHI. It's a username password system. We don't collect anything about their drug use. Everything that's sort of interactive or responsive is done through drop-down boxes, so nobody could, enter the name of the people they'd use drugs with and stuff like that. We also built, a lot of the folks we work with have basic reading skills, so everything's audio-driven. So anytime there's words written, you can also punch a button and it'll read it to you. If you can use an ATM, you can use this thing, you just hit a button. It works everywhere. We have a clinician dashboard, and we weren't that aware of it, but we sort of developed it like a sitcom length. So every episode is about 35 minutes. You can see a little demo. I don't think I'm going to be able to do it there. And just to highlight, we're doing a big upgrade January 1st, which will have a nice clinician and patient dashboard, really easy to use. We kept the content all the same, but we just gamified it a little bit. So you get little rewards for finishing and stuff like that. So it'll be nice. The other thing that we tried to do, and I think we have evidence that we're doing it, is that we're teaching these CBT skills as a way, even Gail D'Onofrio, our emergency room doctor, says everybody can use CBT, which is absolutely true. So we teach skills that people can use to get their substance use under control. But we also connect that very explicitly, that the same skill can be used to basically apply to any other problem of being an adult in life now. So the very first session is about recognizing your triggers. That's, of course, a functional analysis, so breaking every problem down in terms of what happens before, during, and after it, which is really learning, like if you understand a pattern of behavior, you can change it. Dealing with craving or coping with craving is really all about affect and distress tolerance. We make that really clear, that you can use these particular skills, urge surfing or whatever, to deal with craving, but it also helps you deal with feeling particularly, bad or hopeless or even too good sometimes. Refusal skills are just basically assertiveness skills, so persistence under stress, effective interpersonal behavior, learning a little bit of impulse control. Recognizing and coping with thoughts is cognitive flexibility or cognitive modification, which is extraordinarily useful. We try to teach, explicitly teach seemingly irrelevant decisions as they apply to substance use, but it's also a basic decision-making strategy. Problem-solving skills are fairly obvious, and we have a module at the end about HIV and HCV risk reduction, and what we do very explicitly is then go and show how all the skills that they've already learned in the earlier modules can be applied to HIV and HCV risk reduction. So it's kind of fun. And then we had enormous fun making these things because, we sort of became producers. So this is a screenshot from the existing version of the version we have for alcohol. And basically, we just ripped off the TV show The Office. So we have Pam, and we have her jerky boss, and stuff like that. And so what we're trying to also do is get people to just to get really excited and wanted to see what happens to these characters, wants to see how they develop through the end of the treatment as well. I don't think we're going to have time to show this, but there's like a 5-minute demo. It's an old version, but you can see it at cbtforcbd.com or YouTube. And then the other thing that we also explicitly tried to do was have people who are using this really really work with the material, so not just hear or see examples of assertive behavior or craving or something like that, but to actually have to think about it too. So in this example, this is from the assertiveness, saying no thing. We see the character Pam, there's a little snippet where she responds passively or aggressively or assertively, and the person who's using the program is asked to respond about in terms of how that makes them feel. How is it to be on the other end of assertiveness or aggressiveness? So we just, again, it's all, I think, about repetition and memory and trying to be entertaining at the same time. And there's all these little interactive kinds of things too. So this is from problem solving, and we give them a problem like the person's drug-free, but somebody in their family accused them of stealing money or something. And we get them to go through the steps and figure out all the options that they have for solving that particular problem. And so what I'm going to do now is just kind of quickly go through. We now have 6 randomized clinical trials showing that this is fairly effective. So it's ready to move out there. Our very first trial was done in an outpatient program in Bridgeport, Connecticut. The nice thing about this program too is that you can take all comers, any type of drug use, as long as they were using in the last 30 days and not, and actually reasonably stable. But just as an add-on to treatment as usual, we got a 20% difference in percent of negative, percent of positive drugs. We did it wrong that way, for just exposure to this little approach. The other thing that we did was we had a role play task that we delivered before, at the end of treatment, and at follow-up that asked all the participants to articulate what they do in high-risk situations, just to see if they learn these skills. And much to the program's distress, TIU didn't seem to teach a whole lot of skills. We got a nice bump for CBT. It's hard to train skills, but when we brought people back for follow-up, their skills continued to increase even through a 6-month follow-up with no more exposure to the program. So, at least a proxy that we were teaching some skills. And the sleeper effect that we see for clinician-delivered CBT also extends now to CBT for CBT. So this little program kind of hangs on with people and is associated with continued reductions in drug use even after they leave treatment. And then we went next to a somewhat more difficult setting. So these were, the next program was cocaine-dependent individuals who are maintained on methadone. Same setup where we just added CBT for CBT to treatment as usual. They could get up to 2 sessions. There was a bit more psychiatric comorbidity in this particular group. And again, we got not only a sleeper effect, but we got the same level, about an effect size of about 0.3, 0.4. So for a very cheap, easy to deliver treatment, it's a decent effect. We also did a version with that's directed for alcohol only. This time the variation was we compared treatment as usual to CBT added on to treatment as usual. And in this particular trial, we did CBT for CBT by itself, essentially with just 10 minutes of sort of brief clinical monitoring. So they would see a clinician once a week, how you doing, make sure that this level of care was adequate enough to hold the patient. And after this is percent no heavy drinking last 4 weeks. So CBT for itself, by itself, did not quite as well, but really rather good in this population with alcohol use disorder. And then the interesting thing was that this particular setting was very intolerant of people who continued to drink alcohol in an outpatient setting, because basically all they were offering was group. And if someone was drinking at a high rate, they had a very low bar for sending them to either detoxification or IOP. The participants would go to detoxification sometimes, but they would never go to IOP, so they would just disappear. So we went back and just figured out what were the actual costs of delivering the 3 forms of treatment. essentially because the people who were assigned to TAU were either dropped out early. Only 5 of them made to the end of 8 weeks, or were referred out. Whether they went or not is a different story. But when we actually put in the estimated costs of being sent to detox, being sent to IOP, going to jail, treatment as usual ended up being very, very expensive. And then little CBT for CBT did pretty well all by itself. So that was something. No adverse effects. And this is our most recent trial. This is, I think it just came out. And this is not at all what we intended to happen. This was our man versus machine trial. So again, this was an outpatient study, 137 people with substance use disorders seeking treatment, all comers through the door, not a whole lot of people with opioid use disorder. It's a clinic that didn't provide MAT. Mostly male, about half were African American, and what we did was randomize them to treatment as usual. This is Kathleen Carroll trained, supervised CBT delivered by PhD level clinicians. So this was like clinician CBT versus the little machine CBT. And this one was CBT for CBT, again, with just this brief 10-minute clinical monitoring. So this is the end of treatment here. These are days of any use, but the urine's backed it up too. The little CBT for CBT by itself did very well and held on to the effects during follow-up too, which was really not what we were expecting. This was a population with a fair amount of criminal justice referral. So it's very possible these were not people who were big on long individual psychotherapy sessions and a lot of looking inside or anything like that. So this really surprised us because we expected that CBT for CBT would maybe be as good as clinician CBT, and the difference would primarily be in terms of costs, and then we could do some nice things about figuring out who does better in computer versus clinician, which we're in the middle of now. But we were really not expecting the computer to do as well as it did. We also have been looking at various indicators of clinical significance by treatment condition. So blue is CBT for CBT by itself. That's the clinician version. That's TAU. This is the percent who no longer meet DSM-5 criteria for substance use disorder at the end of treatment. So people are looking a whole lot better. And this is ratings of patient satisfaction. So people really like the CBT for CBT too. So, and then again, I'm really excited about this idea of if we have treatment, do people learn? Do they remember? Do they get what we're talking about? Do they understand the concepts and skills? And so, instead of doing that big elaborate role-playing thing, now we have a nice little 40-item true-false test. So everybody in this room would get 100 on it. So people start off about 75. This is TAU. Didn't go much places. Didn't really change much. This is TAU sub CBT. CBT did well, and then the little computer by itself did okay too. So I think we've built a cognitive behavioral training machine that people seem to like. That's semi-disseminable. So now we can go and we can do really good things with it. So one of the things that we've done is, excuse me, you probably recognize her. She's a very famous actress in New York. I got very bothered with having my whole career having to take people who only spoke Spanish and not speak English well enough to sign a consent form and say, sorry, we can't be in our trials. So we developed this culturally adapted CBT for CBT program. It's all in Spanish. And we really learned a thing or two about this. And so instead of having these 7 modules or 7 movies be a little bit disjointed, we really went for it and made this be a telenovela. And so, because everybody wants to figure out what happens to Jesus and Blanca, and are they going to get their daughter back? It's just wonderful. And we teach the skills in it, and the narrator, instead of, some boring guy, is this very wise and wonderful Latina actress She was actually like Salma Hayek's mother in 30 Rock. She was that. But she's just wonderful. And so she does all the teaching, and then she turns to her telenovela, and you see, and this is a program where we had like something like 70% of everybody in the intention to treat sample finish the whole course of treatment. When does that ever happen? So that's great, but does it? There's a nice article on sort of the cultural adaptation. We did it with my colleagues Manuel Paris and Michelle Silva and Luisa Inez, and essentially what we did here was retain the CBT for CBT format and the teaching, but make the movies sort of come alive with issues that are related to common themes of immigration stress, of family separation and so forth. So it's really been fun, and we're right in the middle of doing a new version for alcohol now. So this is now, I think, just now in press in the American Journal of Public Health. This was our old model of just adding CBT for CBT to treatment as usual. We had 92 Spanish-speaking individuals with substance use disorders. A lot of women, which was absolutely wonderful. 95% of them were born outside of mainland U.S. Most of our Latinas in New Haven are from Puerto Rico. And this was the interesting part. We didn't know this when we started. 83% had, in addition to their substance use disorder, at least one current psychiatric disorder. 49% mood, 77% anxiety, 32% psychotic or bipolar. 56% completed them all. Anyway, but we had, again, a very, very nice outcome. But given the high level of psychopathology in this particular sample, we were able to actually look at that as well. So we got the substance use outcome, and this just shows substance use outcomes with higher being worse. These are the 30% of the participants with serious mental illness, so a psychotic bipolar disorder, and these are those without. So you can see that nice sharp difference. Not so nice. So people with high degrees of comorbidity not doing so well. And this is then broken down into treatment. These three groups are all doing fairly well. This, no surprise, is serious mental illness plus treatment as usual. So the CBT for CBT seemed to be effective even for those with serious mental illness in terms of reducing their substance use. It's not a miracle. It didn't reduce their serious mental illness, but early on we can do that. And then this is our sort of newest one. We're also aware, again, how do we push this out there? And we know that one of the many challenges in getting waivered providers to deliver BUP is sort of lack of access to high quality counseling. So we're developing a CBT for CBT buprenorphine treatment. So this is kind of a no-brainer, but it's really kind of fun. So there's a physician tutorial which talks about how to use it, how to go through a buprenorphine agreement with a patient. We have a nice little dashboard for it. And what we did for the patient module was just make everything you need to know about buprenorphine. So every question any patient has asked us, we just have the woman who's playing the physician answer. We have a lot of videos of common problems like talking with your families who's saying you're just substituting one drug for another. There's a BUP knowledge quiz and this 5 A's tracker. So every week they track their adherence to the buprenorphine prescription, attendance at sessions, and so forth. And we've just done a pilot, which is coming out. Oh, that does not look good. I'm sorry. This is standard buprenorphine. This is the CBT for CBT BUP. This is and although exciting, this is 10 people in a group, so we have to do more. Days in treatment out of 84 was 68 on average. In standards, 83% with CBT for the BUP part. We had good and equal data availability, but a really nice difference in terms of percent opioid-free urine specimens and percent of urine specimens that were free of all drugs and alcohol. And I think just because in that module, there's a big session where the woman who's playing the physician says, and you really can't use benzodiazepines, and here's why. And you really shouldn't use marijuana, and here's why. So we make this stuff really explicit, and we train them up on it. Oh, that's right, and Adam was a consultant on this. Thank you, Adam. So that's looking good. So this is kind of where we are now. We have 30 or so peer-reviewed articles. We're starting to make it available. The best part is that it's become a really nice training ground for junior faculty. We have up to 10 new grants that some of our junior people have gotten for adding on fMRI or some of the variations of this. And now we're getting to the, kind of long story short, we're pushing it out into the real world and really trying to make a difference. So we know we have no treatment-related adverse effects. It seems to work across a variety of different populations. We've got some larger replications going on. I mentioned our new alcohol adaptation. We've got studies where we're just popping it in primary, general community primary care clinics to sort of facilitate, instead of people being referred out to treatment, a physician can just kind of provide a little prescription for CBT. They can do it right there in the office. They seem to like it. That's going well. And then a junior faculty member, Ayanna Jordan, is actually delivering it in the black churches in New Haven, which is going extraordinarily well. That's another population where just about everybody who starts it actually finishes it. So it's exciting. And so I pulled the great Herb move. This was very Herb, because Yale wanted to own it, and Yale mismanaged it. It's a long story, but I own it. And so we didn't sell it to, there's no return on investment. We're just making this thing available to anybody who comes to our door. We don't advertise. We make it available at cost. Any money that comes in just kind of goes into making it more secure and those kinds of things. But, this has been just wonderful to see who wants this and who uses it. And our early adopters have been, just really interesting. It's mostly been Native American and First Nation people, so that's not a mistake. That's Prince Edward Island, where you can go, there's a tiny little island. You can go to any pharmacy on Prince Edward Island and get CBT for CBT if your doctor says it's okay and somebody watches you. So we're in about 23 states, a lot of probation officers and so forth. So it's really, it's exciting because there's something evidence-based that's out there and people seem to like it and it's going further. And the other part, which is really, really good, is that when you have something that people want, if they're bad players, you can say no to them, which is extraordinary. So all the 800 numbers and all the catch and release detox places that don't provide medication-assisted therapy, we won't sell to them. And so I got so famous for doing this, I was a consultant to John Oliver. Did anybody see the rehab special that he did? He was like, what are we going to do about drug use? And I said, go after the for-profit rehabs that, don't do good therapy. So what should we talk about? It's like, well, we've got some medication-assisted therapies, and I had to prove to him that they were effective and life-saving, but, he said this on national television. It's so hard for us to push out messages about how wonderful and effective Matt can be, but John Oliver can do it, and millions of people do it. And the other lovely thing that I got to do, except I had to prove this too, was that these places can't advertise horse therapy. There's no such thing as equine therapy. It may be nice to ride horses, it may be swell to ride horses, but I had to actually go and find a meta-analysis that our friend Scott Lilienfeld did, that, because he's just wonderful about going through and proving this stuff doesn't work. And so John Oliver got to say, horse therapy was nonsense. So with that, it's very exciting, and thank you so much for having me, and thank you again, Mr. Hadar, and thank you, everybody.
Both Eric and Dr. Lieberman are here, which is exciting. Eric, I had given a whole description of how your awards have helped both our education in terms of our lectureship as well as our research. This is Eric Hadar, and I just want to give him a round of applause again for supporting us. Okay. And then, Jeff, I did some of the opening remarks for you, so I don't know if there's anything you want to specifically say as well. Okay, so we have the microphone going around or whatever? Yeah, that's great. Great. Thank you, Kathleen. It was a wonderful lecture. It's always so incredibly impressive.
This is Eric Hadar. So, I'm sorry I came in a little late, but I think I caught the gist of it. I certainly caught your upbeat attitude. It's wonderful to hear somebody who's talking in an optimistic way about substance abuse, because it's usually kind of people kind of lower their eyes and they talk about it in kind of somber or regretful tones. And it made me think, there is in medicine, and anybody should challenge me if I'm off base here. There's something in medicine where we have discrimination, medical discrimination, and probably the most overt example of that is something that occurred in this auditorium 2 weeks ago, where we had a conference on psychosomatic disorders, and there was protesters, and it was became kind of one of these controversial events. But you have a whole category of challenged diseases, fibromyalgia, chronic fatigue syndrome, irritable bowel syndrome, Gulf War syndrome, Agent Orange, if you talk to some people in the military, PTSD. And these are conditions that there's some scientific skepticism about. In the case of mental illness, that exists and is probably more extensive. When it comes to substance use disorders, it takes on a moral tone, and it's not just skepticism. It's kind of a residual moral disapproval, or a whole variety of other emotions which become conflated with it, which prevents there being a wholehearted and straightforward and having a all hands on focus on dealing what is clearly of the proportions of being a national crisis and an epidemic. If it's Zika, if it's the flu, if it's the war on cancer, if it's obesity, these things, the NIH, mobilizes, CDC gets on board, everybody gets behind it. And it comes to this, we give lip service. So, as somebody, was one of Herb's proteges, and Herb being kind of such a founding figure in the field, is your belief, since this is, what you live and do, every day, is your belief that we just have to persevere, put out the messages as best we can, let the science speak for itself, and try and get more treatment, or is anything more radical required, like occurred initially with with AIDS, and more recently with autism, in terms of getting, the proper attention to this?
Thank you, Dr. Lieberman. I'm old. I have to sit sometimes. I'm on I saw several of you last week because we're on an Institute of Medicine committee that's about the opioid crisis, and throughout all of the discussions was the role of stigma in kind of keeping people from having access to medications, even the word medication-assisted therapy. These are life-giving medications, and just being, I think, just we as a field, being incredibly careful about our language, how we talk to the people that we work with, how we've moved away from talking about clean and dirty urines. Just to be very conscious of needing to move away from stigma, because I really do think stigma is discrimination, and at this point, it's killing people. And getting the word out, I think, especially for people with opioid use disorder, that we have a range of really effective medications that save lives. There's no question. that they're life-saving, and they can turn people around. And what I learned from Herb is you got to love people with substance use disorders, and he loved them.
Maybe I'm getting too old, but I think it's more than that because, the lip service is given, but the treatments, so you're pushing medicated assistance to make it acceptable to be integrated with the larger infrastructure, which is largely faith-based or
Right.
private, or, Hazelton, or what's the other one with the C? Karen?
Betty Ford.
Yeah, yeah. I mean, you're trying, but health systems, as a rule, don't have a full array of services.
Right.
I mean, ours doesn't,
Right.
and they don't want to.
They don't want to.
And why not? I mean, it's actually could be profitable. So
Very.
the fact that they don't want to makes it mean that it's like distasteful.
It's distasteful, but it's there's too many people dying, and Ned and Robin Williams have this wonderful cascade of care model that if we actually bucked up and took a real public health attitude towards this disorder, we could track it. We can diagnose people. We can put them. We can put them on buprenorphine. We can put them on naltrexone. They turn around and we can save lives. I mean, we wouldn't do this for any other disorder. We would not treat people this badly. I think it's discrimination, and I mean it's up to us and John Oliver when we can kind of get his attention. Just telling people. You don't have to go to rehab. The 12 steps can be incredibly effective, but if you don't want to go there, that's not the only way. I mean, it's taken a long way, but look how far we've come in 35 brief years.
Yeah, sure. Hi. I just wanted to say that my initial inspiration for getting involved in this program and wanting to be some sort of changer in the matrix of how the treatment was approached was because I lived through it myself, and I was able to see all of the faith-based models and the private providers and all of the typical standards that Dr. Lieberman mentioned. But I will say that in the city of New York, the Department of Homeless Services has merged their agency with the Department of the shelter system, the Department of Homeless Services. So you have Human Resources Administration is the acronym for HRA, Human Resources, and Department of Homeless Services together are a $1.4 billion a year city-funded agency that just provides funding for services, including the housing component to shelters, but mainly it's centers for psychosocial disorders, job training, child care, permanent housing placement, domestic skills, medical interventions. There was more, I would say, more advanced treatment methods offered at these centers than there were at any of the Karens or the Betty Fords or the traditional 12-step program. So I think the groundwork, and this is all new, over the last, I would say, half a dozen years at most, has shifted dramatically. So if there is a packaged plan that is easy to translate and to disseminate to the city and to the commissioner of both agencies, who's Stephen Banks, who I've met with on numerous occasions, they are desperately seeking a mousetrap because they realize that it's out of control and the system is broken, whether it's a matter of duration, scope of services, ongoing support. So we've been working and talking about trying to come up with a structure, and I think what you've presented today is as close to that structure as I've ever seen, because it sort of holistically involves, a very patterned and a system that could be repeated and sort of stamped out in a factory and disseminated around the city and the 5 boroughs to service housing. Let's just call it the, traditional Boca Raton, Florida model, where you have a gated community, a clubhouse, and a bunch of home units around it. Right. All right. So I think that this is what has been so interesting about listening to you, is that you've really framed this in a way that is understandable to the layman and can be disseminated and sort of adopted with a ribbon on it. And I really want to thank you for that very much.
I want to thank you. I mean, I think what Dr. Lieberman was also talking was that it's on all of us to change attitudes. But it really takes visionaries, outside of the field, I think, who can affect change. And we're just so grateful, and the work you've done is wonderful. And I want to thank you.
I just want to say one other thing, which is, I think, these things are good. These are ground-up solutions. You're doing an innovative model that's replicable and disseminatable. Eric has been trying to work with and encourage the development of services, for the really rock-bottom, disenfranchised people and homeless. But CMS should, there's a DSRIP program, which is disproportionate share, where they give funds to hospitals to provide certain kinds of services they feel are useful, but hospitals won't do on their own. There should be a CMS mandate to accredited health systems that are receiving federal funds, that they must have a minimally adequate array of substance use disorder services. And I don't know why this idea is not even, I've never even heard of anybody talking about it.
No, and I keep saying this, and it sounds terrible, but if we could stop spending billions of public money on stupid stuff that doesn't work, all the money that goes to these 28-day programs that just, release people and they die, and start, doing small levels of empirically validated stuff. We could make a big dent in this. There is enormous pushback. I can tell you, I'm on an Institute of Medicine committee now that's doing this. There's a lot of pushback, but the time has really come where I think we have the science, we have medications, we have behavioral therapies that are disseminable, that we have stuff to offer that works, I would argue, better. And I'm the girl who wrote the 12-step manual back in her youth. I think the time has come to be enthusiastic. We're not going to save everybody. This is a tool. It's a little bitty tool. It helps some people a little. It helps some people a lot. It entertains everyone. I do, and I think, Herb said you can make a difference, and he pushed us all to do it, and I think we're all children of Herb, and we have to go and carry forward and carry forward.
I think part of the problem is that, for 50 or 60 years, physicians were totally uninterested in treating addiction and abrogated the responsibility, and so as a result, the whole industry and, 12-step sort of took over because it was a vacuum. And I think now we're trying to get back in, and there's really 2 parallel systems going on. You have opiate use treatment, methadone programs. You have, and then this whole idea of bringing treatment into the medical system now. But you still have this enormous sort of monolith of treatment programs that are not engaged in doing evidence-based treatment.
And people, and I think the public's view is the only thing is rehab.
That's all they hear about.
That's all they hear about.
Yeah, Jeff and I did a discussion of Lloyd Setterer's book, and, in it I discussed how, a wonderful movie just came out, A Star is Born, but it was 28-day rehab. That was the treatment.
Yeah, I know.
And it drove me crazy. It was great for the suspense of the movie, but,
Right.
That's what everybody sees.
Right.
I know Effie's waiting to say something, so Effie?
Yes, Kathy. Thank you again for a wonderful talk. As always, it's a pleasure to listen to you. And you made also a great dent in the in therapy. And what I was thinking, listening to you, we reached as a field at the point that we followed the stage models that you, Lisa, and Bruce put over 30 years ago with the guidelines, right? It's about 30 years ago.
Yeah, I'm so old.
And so we do have wonderful evidence-based therapies like CBT for CBT. And with the current technology, we have the ability to spread it out.
Right.
Where I'm right now struggling as a clinician and as a researcher, having a wonderful tool too,
Yeah.
maybe to have, what we may be missing is another stage model, but how to disseminate, how to take these wonderful tools that been developed over the past 3 decades or more, and how can we just spread it out? So I was fascinated to see your wonderful last slide, how you've been doing it across the country. But how do you do that? What do you do? How you reached out?
Yeah.
How you publish yourself regarding the CBT for CBT? That's my question.
write that paper,
Maybe
Ab.
it's about time to write the paper, not about how to develop treatment,
Right.
but 3 stages, how can we go about dissemination?
And then needing to think, even when you're developing a new one, focusing on the mechanism so you know what the it is, so you know what you're trying to do. And then right from the beginning, you should think about how do you push it out there. And because I didn't know anything about insurance systems and CMS and HCPCS codes and blah, 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 blah when I started.
So how do you disseminate? How you get to those early adopters of yours? How they get to you?
They came to, so far they all came to us. One thing we did that I said no to a lot of people who wanted to market for us, because there's a lot of nasty people out there. There's a lot of good people, but there's a lot of nasty people. But about 6 months ago, we went into partnership with Chess Health, which is Dave Gustafson, who's the brilliant guy at the University of Wisconsin, came up with an app that's very connected. It's connecting people kind of thing. So CBT for CBT teaches you the skills, but doesn't do the motivation or the social isolation part. His piece does the socialization part and the data stuff. So, I think when you get to the dissemination, you need to work with people who know something about the healthcare system and how it's done and financed. And so, by going into partnership with Chess Health, they have salespeople. They're wonderful, and their heart and their soul's in the right place too. So I'm not going to leave my day job, And if I say you can't say that because the paper's not published, they go okay, which is really, really nice. And I said, you can't sell to the for-profit rehabs, and they say, okay. There's not many people who like that, so yeah.
How to do research, RCTs.
Right.
But we are not trained. I don't think we
Yeah.
have the right platforms yet.
Yeah,
How to disseminate our good work, our evidence-based
Yeah.
therapies right now to the world who are willing and at least to take a chance and use it.
right,
Because we have the data. We show that it's working.
right.
How do we go out there and say?
You have to show the cost, too. You have to show the cost savings. That's the thing. You can have the most effective treatment in the world, but unless it saves the insurance companies money, they're not that interested because they're so stretched. Anything that adds cost, they're not interested in. I'm learning these things painfully. And you know where it's really easy to disseminate? Is Canada, because they have a health system and everything makes sense. So they go, oh, yeah, that's a no-brainer. Vroom. And in America, you're kind of like, oh, well, we can't.
So I have thank you for this wonderful talk. I have a comment about this conversation, and then I have a wonky question. Wonky stuff. We're up against philosophies and belief systems here. I was visiting some colleagues in Buffalo a few months ago and meeting this wonderful young psychiatrist who is collaborating, starting to work in a traditional counseling-based treatment program prescribing buprenorphine for opiate addiction. So this is terrific. Sounds great. This is just what we want. It says, yeah, but you know what? If the urines don't clear of opiates in a couple of weeks, they discharge the patient. And she says, I can't convince them that this is crazy.
Right.
That you're doing the equivalent of discharging the patient because they still have sugar in their urine when they have diabetes.
Right.
But this is what they believe.
Right.
And so I think we're up against beliefs and philosophies. I'm not sure how you deal with it. I think it's we have all the evidence in the world that we show the evidence. That doesn't matter because it's not what they believe.
Yeah.
So it's a tough problem. Now my wonky question. you and Roger published this beautiful article in American Journal, like within the past year, about
Yeah.
what kinds of behavioral therapies work in conjunction with buprenorphine for treating opiate use disorder, and
Right.
concluded that the evidence there is for contingency management,
Right.
which is a very concrete approach as opposed to, your beautiful work with CBT and trying to teach people skills that they'll retain and that will grow over time and create a sleeper effect and so forth. So you must have thought about how to integrate contingency management into CBT for CBT. What are your thoughts?
Yeah, no, I mean, TES does that more, the TES.
Yeah.
Yeah, I mean, it's,
But TES doesn't have the same production value.
Yeah.
TES is not a telenovela, right? It doesn't have the same.
I'm a producer.
Yeah.
I know.
Yeah,
I am. Which is fun. But, yeah, so I think you also have to be multidisciplinary. So I'm a terrible salesperson. This is as close as I can get. Please use my program. It's really effective and cheap. No, don't hurt me. But then with partnership with Chess, they just sell it and I don't have to, and I can say no. But one of the, so we've learned, they know that system, that's fine, and I trust them. But we actually, to do like CBT for CBT Mach 2, we found really good web developers and designers, and we said we really want to gamify it too. So the content's the same, but, you get stars and whistles for everything you finish, and it goes back to your clinician, and you get that kind of thing. I don't know if it's the monetary thing, but I think, a lot of our patients don't have a lot of experiences that they can really feel good about. And our little certificates and you get your 5 little brains and all, which is good. And,
What he said is going to do is that incorporated into the insurance payment is going to be contingency.
Yeah, that's good.
Okay. Sally, do you want to say anything?
Sort of an idea.
Okay.
You could do that.
Good.
Great talk, Kathy. Thanks so much.
Yeah.
Well, yeah, I think it is. Hi, Dr. Lieberman. Actually, I was going to just throw in a comment with respect to your question, which is that, when you have reluctant, when the landscape is hostile to, reluctant to absorbing new kinds of treatments, the last thing they need is dissent among the ranks of the people who are proposing the improvements to them. So I'll in other words, the treatment community has to speak with really one voice. And I don't mean to say that one is superior. In fact, the messages, of course, they all have value. But when there's, it's very easy to dismiss someone who's appealing to you by saying, well, they say this and you say that and you say that. And you're all doctors or you're all psychologists, you're all clinicians. So that's just an important element of trying to, advance an innovation is to not have too much dissent among the ranks.
Yeah.
Debbie?
Yeah, no, and we will sell to those people if they take the horses off their website and they start offering Matt.
What's the question, Jeff?
Change the world, a little bit at a time.
So I had a question. So Kathy, thank you for such an amazing, wonderful talk, so upbeat and interesting. I mean, if the treatment is as engaging as the talk, then you're home.
I'm a chatter.
So the thing, something caught my eye at the end, which was, integrating CBT for CBT into SBIRT. So SBIRT, people have been thinking for decades that, primary care is the ideal place to intervene for alcohol and for drugs, and they think it's great and it really should be done, and especially the referral for treatment, the RT part is so much wishful thinking. It would be so perfect if they would just take the referrals and go to specialty treatment, which they never do. And so I was wondering if you could just talk a little bit more about what you're doing with that. Is it for alcohol where SBIRT works better? Is it for drugs also? Are people doing it? Are clinics adopting it? If you could just talk a little bit about that, because it seems like if it works and engages providers as well as patients, it seems like it could be part of the solution to this dilemma that's been in place for a long time.
Yeah, I think that's I think that's a really good way to do it, because like the specialty care is already doing pretty good care, that's there. So it's getting to the people who aren't using it. So we started, but I started in the wrong place with my friends. So Jeanette Tetreault and Steve Holt are wonderful people from our addiction medicine department that have a specialty substance abuse clinic within a large primary care clinic. And so we just finished a pilot study, a randomized pilot study, where the physicians and nurses who would pick up somebody in this clinic with a substance use disorder, could be marijuana, alcohol. They tend to keep people where they have a medication to give, so naltrexone for alcohol and MAT for opioid use disorder. And we just you can just sit at the kiosk. We got a broom closet with a little computer and let people do it. And again, it was like close to 50% of the people going all the way through to the end of it. So it's feasible. The problem is that these doctors are also nice to the patients. Really nice. They had really good it's when you go into some of these primary care clinics that love to treat substance use disorders and feel good about it, that's 90% of it, because they'll call you like, Mrs. Smith, and how are you today? And they treat the patients with respect, and guess what? They do pretty well, and they keep coming back, which is really sort of interesting. So, how it'll do with, people who are not as, it was a teaching clinic. It was really, really nice. So we're going to try to do it by prescription in some places that are a little bit more hostile. And then the Butte data was just almost too good to be true. That was in the primary care clinic. So we're going to try to, spread out and do that in some other states as well. Do a randomized trial, where there's going to be more variability. But I think that's a really good idea too. And I kind of like it, like at the minute clinic. Like your physician can say, here's the thing. Do this, you do 7 sessions, it'll be okay, you'll learn a thing or two, it won't hurt you. If that gets your, if you stop having substance use problems, that's great. If it doesn't, maybe we should, go to another level. I mean, I could just, we can be nice and respectful to folks and do it. So I think it's a cool idea. Yeah.
So I really enjoyed your talk. Thank you so much for that. And we've been talking a lot about dissemination. I want to ask you a question about the most surprising slide for me was the man versus machine slide. And what really surprised me is you were comparing not just treatment as usual, but your expertly trained clinicians against CBT for CBT. What I want to ask you is, what is CBT for CBT doing that's unique and different from your expertly trained clinicians? Because it seems like there's something different about that experience. And then what can we learn from the machine? What are some takeaways that we can take from CBT for CBT and begin to apply those strategies that it might uniquely be doing than your expertly trained clinicians?
Come work for me. Herb used to always try to steal me, so he come here. All right, so that's a really good question, and I don't know that I know. I know we put so much effort into making the CBT pretty and usable, and interesting, and okay, people are just going to like it, and I worry that the implication of the clinician piece is that a lot of times we kind of know that some of the patients love it, and some of the patients don't want to talk to us. They don't like what we got, in some ways. So I think figuring out, who is it that really needs the connectedness and the clinician, and who's like, okay, I can do it. I think that's an interesting thing. I think another, Ned was talking about contingency management. That's fun. That's a fun treatment too. So kind of thinking about, the specialty treatment. People hang out in the parking lot and they wait in line, and we do kind of nasty, mean things we wouldn't do to. So making treatment inviting and fun, and I think that's part of it. But I do think there's no question in my mind that there is and always will be an important role for expert clinician-delivered therapy too. And one of the things that we're doing in that data, we've got fMRI data and all kinds of secondary outcomes we haven't looked at yet. But like one of the things that we saw, that people who were higher in alexithymia, really needed the CBT and did much better with the clinician CBT. So I think it's, somebody with the, severe stuff and high comorbidity and, somebody that my Brian would call a walking SAE, they need a clinician, but somebody who's like early on and uncomplicated and not so severe, maybe a little CBT for CBT is, it's maybe a resource thing, but.
Okay, we're going to take one last question because we've been.
I can rant.
I love the ranting, but we want to make sure everybody gets out. So one more question, and then people can come up afterwards if they have a question for Kathleen. Nasser?
Thank you very much for this very compelling talk and very enjoyable. So in terms of thinking about dissemination, it seems like it's already been kind of paid for in a sense. It's developed. It's in the can, so to speak.
Yeah.
So one idea, which you may not like, is why not make it completely free? And then number two is why not just cut out the middleman of clinicians and just make it freely available on the internet and go talk to Google and say, well, put this on when people search for, I need treatment for my drug problem, this just pops up in the top.
Those are great questions, and we've wrestled with them too. One is at this point, I'm still in. There's an awful lot of people. I still want a clinician to eyeball everybody who uses it just to make sure that this is an appropriate thing for them, that they don't need to be in the hospital, that that if they have opioid use disorder, they can get mad if they want it. So I want a clinician involved, even with brief monitoring. And as the data get farther and farther away, we may get there, but I don't want to get ahead of the data and just say, CBT for everybody regardless. Even in Prince Edward Island, where you can get it through the pharmacies, you got to somebody has to make sure this person's okay. I think that's true. And so when I was getting this away from Yale, I really there are two models in academia. You either give it away for free or you sell it to some big company with return on investment. And if you made it available for free, it doesn't get better. There's no bar to using it. And I want this thing to get better. I would any money we make. I really want to make a version for the black churches, and I'm not going to get NIDA money for that. I want to, whenever the first people who came to us were the First Nation people on the Lennox Island people. I want to make a version for them. I want this thing to get better and get more gamified. And so, a little money has to come in. So we do make it available pretty much for cost. But, I want it to get better and stronger and, do some good. And and if I was doing that, I couldn't be talking trash to all these detox people,
Right.
which I really do. I say, come to me when you take that crap off your website and are offering real treatments, and they do. It's pretty good. I never saw that coming, so I'm just having fun.